Good evening, ladies and gentlemen. Welcome to this evening. Apparently it's very cold in Cape Town, and I'm sitting in the north in Pretoria, and it's not that cold, it's manageable. I'd like to welcome you to the webinar. It's a webinar by us, EthiQal and APRASA. My name is Hlombe Makuluma. I'm the medical legal advisor at EthiQal. The webinar has 2 ethics CPD points. So it's going to be very important that those that have attended, to make sure that we have their correct names, their MP numbers, and their contact details. Today we have our main speaker, Marshall Murdoch. I'll introduce Marshall later. Mashuma Parker, I'll also introduce Mashuma later. And we also have Professor Tim Christophides. Tim is the president of APRASA, and he's the one that's going to give us the official welcome. Can I hand over to you, Tim, just to say a few words, and you're welcome to us to this webinar.
Thank you very much, Dr. Hlombe. Good evening, everyone. I'd like to officially welcome everyone to this webinar, which will cover the HPCSA complaints and ethical considerations of performing aesthetic treatments during the COVID-19 pandemic. Both very interesting sort of topics. Our moderator, as you may have gathered already, is Dr. Hlombe Makuluma, and he's from EthiQal. We as APRASA are very fortunate to be able to position ourselves in a very sort of, like I said, a fortunate position to be able to partner with institutions and companies such as EthiQal and many others, where we are able to arrange these webinars for the benefit of our members. In this particular situation, this webinar has been initiated and arranged by EthiQal, and it has been sort of contributed to, as you may already gather, by APRASA. It's important for us to actually contribute to all of these webinars and so on for all of our benefit. And Dr. Hlombe has already mentioned that we do gain some CPD points and so on. And it's very important for us to keep up to date with both medical and non-medical issues in the medical business side of our work. So we're going to be hearing from Ms. Mashuma Parker, who's a legal advisor and part of the EthiQal team, as well as from our esteemed colleague, Dr. Marshall Murdoch, who's a plastic and reconstructive surgeon, as you know, and is also a member of our executive committee of APRASA. I'm going to hand back over to Dr. Hlombe, and I'd just like to say one final welcome to everybody, and I hope everybody enjoys this webinar that we've arranged. Thank you very much, Dr. Hlombe.
Thank you, Prof. Without wasting a lot of our time, I think we should, I should start introducing Mashuma. And Mashuma is going to give a presentation, but we really don't want the kind of information that is, when we still had to sit around in conference rooms, we're always told death by PowerPoint. So we're going to present this differently with Mashuma. Mashuma and I, we talk every day. I'm the medical legal advisor, clinical background. Mashuma is a legal advisor, so legal background. So we've got a tendency of talking a lot because I don't understand law very well, and she doesn't understand clinical medicine very well. And I think all of us seated around, we have that. So we're going to have a conversation with Mashuma around the complaints, HPCSA complaints. So, Mashuma, are we ready?
Yes, Dr. Hlombe, we are.
Great. Mashuma, we did a lot with HPCSA complaints. And these HPCSA complaints, I think, they really do cause a little bit of gray hair for you and the rest of the legal team. So the basic question for me would be, what does HPCSA do? Let's start there. What is it that the HPCSA actually, what's the mandate? Explain it to your 5-year-old daughter.
Okay, so simply explaining what the mandate of the HPCSA is, I would say that it is the HPCSA regulates the conduct of health professionals in South Africa. As simple as that. Yes.
So are they're there to look after the doctor's interests, or are they there to look after the patient's interest? What is it?
The mandate is a bit wide. They regulate, I suppose, not only professional conduct and ensuring that doctors and professionals comply with the ethical obligations, but they also engage in, I suppose, training and education of doctors, and also to ensure this continuous professional development. So it really is to see that the professionals that are registered with the HPCSA complies with their obligations in terms of regulation and I suppose ethical behavior too.
Right, great. You have dealt with a lot of HPCSA complaints that are coming from, our policyholders, and there are some challenges that you face. If you were to give just briefly an advice or guidance that would make your lives as legal advisors and the lives of our policyholders better when they receive an HPCSA complaint, what would it be?
So I suppose the one common aspect or difficulty that we in the claims team at EthiQal actually experience is late notifications of these HPCSA complaints. So I suppose the best thing that professionals can actually, or practitioners can actually do to assist us is first of all to provide us with timeliest notification of these HPCSA complaints. That's the first step, Dr. Shlombe. Following that also, I suppose that the best way for practitioners to actually assist us is by holistically considering the HPCSA complaint, to look at the scope of the complaint. What is the relief sought? Is there valid patient consent? From that point onwards also to look, I suppose, with a deeper lens to see what are the direct allegations that are lodged against this practitioner, and then also what the indirect allegations are. To then apply the practitioner's mind, I suppose, by relying on their patient records, to draft a report setting out the treatment and management of the patient for purposes of putting us in the claims team in a position or context what exactly happened. Following that also then, I suppose, to provide us with some written explanation or response to those allegations contained in the complaint.
It seems like really mentioning things that are problematic for you. Do doctors actually submit very late, or they give you very brief notes or notes that you can't see? What's bothering you?
So I suppose, as mentioned, one of the common difficulties that we find, first of all, is late notifications of these complaints. In addition to that, also, we see that, and we understand at claims, we actually understand that doctors are busy, practitioners are busy. So I suppose doctors are inclined to maybe look at the glaringly obvious allegations that's listed in the complaint, and to then overlook the other information or the other allegations, maybe indirect allegations or probable medical legal issues that can prove to be problematic later. So I suppose that's the one thing. And then secondly, also, I suppose that not being provided with sufficient information for purposes of actually responding to these complaints. Yeah, I think that is it.
Right. Maybe I should just come closer and say, what types of complaints that are common that we get from, or that you guys get from HPCSA?
Okay, so let me quickly, so I think a way of answering this question, what we seem to find is that a lot of complaints actually relate to the informed consent communication process. And when I say informed consent, I suppose in the broader sense of the word. So whenever I'm reading an HPCSA complaint, it seems so starkly obvious that there just seems to have not been meeting of the minds between the patient on the one hand, or the complainant, and the practitioner on the other hand. So it's not necessarily to say that the practitioner didn't engage the patient about the information needed to put that patient in an informed decision to decide about that particular patient's health status, but it's not automatically or not a given that the patient actually understood the information. So informed consent, in the broader sense of actually understanding there being this meeting of the minds, that is, and all other aspects, I suppose, relating to that. And then another big thing, which is also an extension of informed consent, is a lack of informed financial consent. Yeah.
When you say lack of informed financial consent, can you give us an example? What is that? Maybe doctors paid or patients pay a lot, or what is that?
So I suppose what we've seen a lot of lately, it usually comes in the form of, it's not to say that it's a given, but it comes in the form of these minor ombudsman complaints, where the ombudsman is actually tasked with seeing if there is any transgression, even if it's a minor one of the rules. And what actually happens is that, I suppose, in the same way that practitioners need to ensure that that patients understand all the benefits, risks, consequences of whatever perhaps diagnostic treatments that they are going to perform on the patient, they also need to put the patient in a position to understand the financial aspect of it. So I suppose to understand that if there are going to be any co-payments, so this is what it's going to be. If there are complications, what happens to the cost of those complications? Who actually who's the one that's going to have to cough up these? I suppose extend it a bit further to say that it's not only me, if it's an OBGYN, it's not only the OBGYN, or it's not only the plastic surgeon that's going to be involved. There might very well be a anesthetist or somebody else that needs to be called on too, and that there might be costs that's incurred there too. So I suppose just putting that position, that patient in an informed position to be aware of that and to nevertheless agree to actually to incur those costs.
Right. You talk about an ombudsman's complaint.
Yeah.
Please explain to us how the HPCSA works. It seems like different complaints that goes to different places.
Yes, so they are. So there's two types of complaints. And the first type of complaint that we at the claims team, we refer to it as ombudsman complaints. And then the second one is the preliminary committee complaints. So when the registrar of the HPCSA actually receives complaints, they are obligated to categorize the complaint in accordance with significance and seriousness. Where it is, I suppose, a minor transgression of a minor transgression, something qualifies as minor transgression, or it's something that doesn't fall within the jurisdiction of counsel, then this will be referred to the practitioner via the Office of the Ombudsman. On the other hand, for, I suppose, more serious allegations or complaints, these will be dealt with by an office called the Complaints Handling Unit and Investigations Office at the HPCSA. And those, I suppose, for more serious allegations.
When you talk of serious allegations, what do you mean from a sanction point of view?
So I suppose from a sanction point of view, and maybe one thing I should also say here is that ombudsman complaints, despite being minor in nature, it may very well be that a determination is made by the ombudsman, but it's maybe not agreed to by either parties, and then it actually then escalates to the next level of a preliminary investigation, and then it also actually warps into a preliminary committee complaint. And so it's not always to say that it's only these sanctions in terms of the Act can only be imposed for preliminary committee complaints, but it might very well be that and hopefully not that it actually goes further for these ombudsman complaints if they escalate. So by way of penalties, in terms of the Act, they vary. It might be something as simple as a caution or a reprimand. It might also even be both. It might be a fine, imposition of a fine. It might be suspension for a specified period of time from practice for in a particular area that the practitioner practices. It might even be removal of the register or a compulsory period of professional service. And then lastly, it might also be that the practitioner is required to pay the cost of proceedings.
You initially spoke about, delays. I think there was a time when you spoke to me about, what do you call it, contempt or
Contempt of counsel.
What is that? Contempt of counsel. What is that? You once shared with me that, just explain that what you shared with me the other day.
Okay, so I suppose one thing that practitioners, and the lesson you really hear, is complying with the time limits or the due dates of the HPCSA. So unfortunately, it seems to be something that is, it's not taken seriously, but I suppose not taken as seriously as it should be. So if there is a due date given to the practitioner by the HPCSA, it's very important for the practitioner to understand that they need to actually provide the timeous submission of the response to the documents required by the HPCSA. And if they don't actually do this, what can happen is that they can actually be held in contempt of counsel. And this information is actually communicated to the practitioner in the preliminary committee complaints, in the cover letter. All this information is actually entailed there, which actually means that the impositions or the penalties that we spoke about earlier might very well be the case for this contempt.
Is there something that a practitioner can do to avoid, because that contempt it happens even before, the complaint has been heard? Is there something that I can do to avoid at least the contempt part?
Well, yes, most certainly there is. First of all, like I said, timeous notification to first for the practitioner to just make sure that he knows or she knows who the professional indemnity provider was, that they were insured at the time. And as soon as they've actually established that, to forward it almost immediately upon receipt of the complaint to that person. Obviously, then what we do is we actually try to take the complaint off their hands, and then to request of them to put us in a position to assist them. So that almost trying to take the stress away, I suppose, from them.
But how does HPCSA contact the practitioners? Is it by email? Is it by phone? Is it by sending a registered letter?
So I do know they actually do send via post too. But what we lately, what I've seen more commonly is that it's actually submitted to the practitioners via email. And so I suppose one thing that's important here, if I could communicate anything to the practitioners, it's really to ensure that the email address that they've lodged, I suppose, or registered with the HPCSA, that they actually are checking that, they're checking that email address, just to make sure that obviously there are no complaints, and then to, I suppose, avoid any contempt of counsel.
I'm glad that you're talking about email, because one of the things that really, a huge challenge is a lot of practitioners just checking their emails. So if there's one piece of advice, please check your email regularly and know that which email is actually registered with the HPCSA. Is that a good advice?
Perfect.
So, coming close to the end, just because of time, the one question that I always get is, there's HPCSA complaint, which is the regulatory body. There's also litigation. Is there a relationship between HPCSA and the court systems? Is there, can a complaint go into both, or it needs to go to the HPCSA first, or just give us briefly?
Okay, so I suppose the way to answer this is to say that obviously the court system on the one hand is a bit different to the way that the regulator, the HPCSA, the regulator And I suppose the perspective or the lens through which the HPCSA is looking is a bit different to compared to the lens that the court or the judges will look at. From the way it's not necessarily to say that the one is dependent on the other. And it's not always to say that if, for example, an HPCSA or the HPCSA finds or makes a finding of unprofessional conduct, that this necessarily follows that if the matter were to go to court or is simultaneously in court, that there will most certainly be a finding of negligence on the part from a court perspective. So it is possible for legal processes and these HPCSA complaints to take place, I suppose, simultaneously. What we usually find is that I suppose patients are more inclined to first try and see what happens with the HPCSA complaints prior to then deciding whether they want to institute a separate, maybe I suppose, summons or something like that. And then the other thing also that is important is that the standard so the HPCSA will actually they will investigate into unprofessional conduct. The conduct of, they will look, I suppose, at consensus, they will look at the ethical guidelines and the regulatory framework. From the court's perspective and from a judge really, they will then look on a balance of probabilities and they'll then try to see the reasonableness of the practitioner's action. So it's not necessarily to say that like I said, if a practitioner is found to be unprofessional in the HPCSA, that they automatically will definitely have been found to be negligent in a court. It's not necessary. It might be used as a motivation, but not automatically.
Right. Thank you for that, because there's always been a confusion, because I think most practitioners would think that, if you're found to have been, they say that there was no sanction from the HPCSA, the court system will just say, fine. I mean, they negligence against the practitioner. Who complains a lot? From the HPCSA complaints, who are the complainants? Who are these people who put doctors into these difficult
positions? So while Dr. Slope, it can actually, first of all, anybody can complain to the HPCSA. But most of the time we see that it's the patients themselves. And for, I suppose, like I say, because of just this lack of meeting of the minds, they can say there was no consent. They can say you took my ovary out, you were not supposed to, I didn't agree to that. They can say a host of things. So it's really sometimes the patients, or it's, I suppose, the complainant that's not necessarily the patient, may very well be next of kin, or it may very well just be somebody related to the patient. But like I say, it's broader than that. It can be anybody.
I would assume that for plastic surgeons, especially those that specialize in breast augmentation, husbands complain a lot.
So maybe not husbands, but actually the patients definitely. I suppose the expectations, the ones, especially when it comes to these breast augmentations, the one I'm actually busy with a complaint at the moment, 2 of them actually. The expectations, I suppose, of the patient, it's just definitely not what was communicated to them by their practitioners. So it's unrealistic, I suppose.
If in 1 second or in 3 seconds, you could give just one advice before we close, take-home message for the practitioners, what would that be?
Timeous notification of HPCSA complaints, first thing. Secondly, I suppose I always feel that if I were in the position of the professionals, the health professionals, I would invest some time in actually sorting out my informed consent documentation, just so that I can ensure that patients actually, that I protected myself, even if the patients maybe didn't understand what I was saying, but at least that I know that if something were to come, that I can protect myself accordingly.
All right. Thank you very much, Mashuma. Looking at the time, I'm just wanting to, we can continue with this conversation for another 2 hours.
We can.
There are lots of other questions, but thank you very much for giving us a little bit of an understanding of what the processes are and what you guys are dealing with. Thank you very much.
Pleasure. And thank you to you, Dr. Schlumbe.
All right. Putting a different hat And quickly, we're going to take questions and answers. Please, if you have some questions, please put them down. We are going to address all the questions at the end of Dr. Marshall's presentation. I think at this point, I should call on Dr. Murdoch to give us your presentation, please.
Thank you all for coming to this webinar. And if you attended ISAPS World, this is like a really fleshed out version of what was 6 minutes at ISAPS World. So I have a bunch of other slides, and I can also talk a little bit slower than I did on the ISAPS World talk, but it's kind of another ethics talk, and this time looking at whether or not we should do aesthetic surgery during the pandemic. As always, there's a difference in ethics and morals, although people think they are the same. Ethics is a study of principles that govern behavior, and it's applied to individuals, to groups, and to whole societies. And it comes from Aristotle in his book, The Ethica Nicomacheia, basically means character. Nicomacheia was the name of his father and of his son. So it's either the wisdom I give my son or the wisdom of my father. And then later on, sorry, I don't know why that went. Later on, several decades later, Marcus Cicero translated that Greek word into Latin and named it morales, pertaining to manners. And he called it the distinction between right and wrong behavior. So one can really say that ethics is the thought behind an action and morals is the action itself. When I said it applies to groups and individuals and whole societies, just consider the difference if you were, sort of eating your breakfast in Trafalgar Square versus living in the favelas of Rio de Janeiro, or if you were sort of a nomadic tribesman in Kashmir or a monk. All of these people would have an ethical thought or consideration, but it would be vastly different because of the society and because of where they live and what they do. So we need to have some kind of framework on which to hang at. And here are sort of four schools of thought when it comes to ethics. And the first is deontology, which is the main proponent of which was Immanuel Kant, although he wasn't the first to describe it. And it means obligation or duty in Greek. And Immanuel Kant called it the categorical imperative. And what he meant was you should do everything according to the rule that it should be universal. So, for instance, deontologists say that killing anyone is bad, and there is no such thing as an acceptable murder of anyone. So they would then object conscientiously from war for the same reason. So one can sum it up in the single statement: do good regardless of the outcome. And that's directly opposed to utilitarianism, which is almost the exact opposite. And it was coined by Jeremy Bentham in his book, An Introduction to the Principles of Morals and Legislation. And people say that's the greatest good for the greatest number in a single catchphrase, but it contains these three important parts. So actions are judged only by their consequences, and the only consequence that matters is the happiness or the unhappiness that's created by that action. And if multiple people are involved, every single person's happiness has the same value. So the greatest good for the greatest number, or the greatest happiness for the greatest number. Individualism was proposed by John Stuart Mill, and it's what we would call democratic rights, or in the American Constitution, if you can sum it up in a single sentence: life, liberty, and the pursuit of happiness. And it basically supposes that one can only exercise power over anyone else when it is to prevent harm to others. So everyone can do whatever they feel like, as long as that does not involve harming or in any way disadvantaging someone else. And again, that is in contradistinction to communitarianism. So this was proposed by English Minister John Barmby, and he stressed the communication between the individual and the community, what we would call in South Africa Ubuntu, or I am because we are. So if you had to place yourself on this moral system, everyone, there's no such thing as a pure deontologist or pure utilitarian. Everyone is going to be at some point on this top spectrum. They'll find themselves somewhere just according to their own principles, and they'll find themselves also on a socio-cultural background on some area of the spectrum between pure liberal individualism versus communitarianism. And so if you think about this sort of three-dimensional block, you also aren't always in every situation acting in the same way. So there is some flexibility as well. So you find there's an X here and there's an X there. These two people represented by these two X's have two completely different outlooks on any particular problem. And that means that there's no such thing as a universally ethically right answer to any problem. So we have to kind of have to decide where we stand, and we have to articulate that and defend our particular stance to our peers and to the society in general. So the principle of principlism takes into account these four factors. It takes into account these four factors: beneficence, non-maleficence, autonomy, and justice. And these are the principles of modern medical ethics, and they basically came out of the Nuremberg trials, from the concentration camp experiments that were done on people during the Second World War, and then they were formalized by the World Medical Association with the Declaration of Helsinki in 1964. But as I mentioned in some of my other talks, things like the Tuskegee syphilis study, which continued despite all of the above, and which was a serious breach of medical ethics, led to the formation, and it was specifically the Tuskegee incident, which led to the formation of the Commission for the Protection of Human Subjects. And that is where the idea of principlism was put forward. And that is now kind of the way medical ethics is examined. So people often ask, if people have multiple viewpoints and they're all valid, what's the whole point of principlism? So the value of principlism is to examine a problem, to articulate that problem, and to defend your personal or professional decision using these four principles. So to go through the principles, the difference between non-maleficence and beneficence, of course, for surgeons is separated by the knife, because the principle of first do no harm, or primum non nocere, was first proposed by Hippocrates and is part of the Hippocratic Oath. In fact, in the Hippocratic Oath, surgery is actually forbidden, but surgeons, of course, will have to cut patients. So we have to kind of harm them. And that's why the informed consent process is so important. We have to harm them to be able to help them. So when one considers the beneficence, the benefit of an operation, you must always consider the operation, the risks of the operation and the benefits of the operation, and also the risks of refusing the operation and the benefits of refusing the operation, because there is a risk to refusing as well. And all these things like complications, the costs of it, the downtime, and the potential results all play an important role in balancing out this equation of when to operate and when not to operate. Autonomy is highly prized in medical ethics, and it's said to be the freedom from external control or influence. And it has these important factors. So knowledge, or one would say like the consent process, is to provide knowledge, and then for the patients to understand that knowledge, and then to have a freedom of choice based on the understanding. This is, of course, assumes that truth is told during that consent process. And then there's two other parts. One is capacity, which refers to understanding in the clinical context, and competence refers to a legal consent. So it's important that someone who might be under the age of competence might have the capacity to understand, and someone who is legally competent might not have the capacity to understand, especially if they have subnormal mental sort of faculties, like patients with dementia, for instance. So those are two important concepts. Just keep it in mind. And then I haven't touched on this a lot before, but distributive justice is an important concept, and that's going to be the crux of the talk. The provision of anything which is limited, such as healthcare, will have to be divided, and we look at resource accessibility and resource availability, and ultimately it's going to be economics and politics which determine how distributive justice is effected. And there are a whole bunch of paradigms when it comes to distributive justice, or distributive paradigms. So here are a whole bunch. There is, for instance, on the left, egalitarianism. So the egalitarian paradigm says that everyone gets an equal share regardless. And you can obviously see if you just divide the pie up into equal slices and everyone gets the same, but there are, of course, problems with that. Equity-based, or what we call welfare-based or needs-based, is those who need the most get the most. And while that sounds very exciting, it's sometimes much harder to do in actual practice. Merit-based or desert-based, or what we call libertarianism, is you get what you can afford, or you get what you work for, which is kind of the basis of modern capitalism, I suppose. But that leads to, as you know, significant inequalities. And then there's what I call utopia. Everyone's free to get whatever they want, and there should be no restrictions. None of these systems are perfect. In fact, most of them have significant flaws. And everyone says, well, it wouldn't be wonderful if there was utopia. So utopia is a place, it's a continent, and it's a strictly fictional place because it was written by Sir Thomas More. And the book is now 502 years old and describes a society where everyone gets everything they want and there is no need whatsoever, and there's more than enough resources for everyone. And of course, 502 years later, this remains absolute fiction still. So how do we view an ethical problem? Basically, instead of thinking of them as pillars, think of them as balls on a table, and you're going to saw one leg off the table so that that ball is going to drop down. So you obviously can't let any of the balls drop, so you're going to have to hold up the kind of ethical weight of one of the principles which have to be compromised. Of course, if none of them have to be compromised, then you don't really have an ethical problem. So the question really is, which leg and why? So if we look at the role players when it comes to should we perform aesthetic surgery during the pandemic, well, there's the surgeons and then there's the society, which includes our patients. And different actions are taken by different role players. And of course, what surgeons do and what surgeons say will affect what society thinks, and what society says will affect what surgeons do and think as well. But society and surgeons have different sort of roles. The surgeons can either perform an action or refrain from an action, and that is all. And society can allow an action or restrict an action. So when it comes to things like autonomy, there is kind of an evolution of autonomy in the beginning of sort of like modern Western medicine, and right up until perhaps only 20 or 30 years ago, paternalism in block number 1 was the most important autonomy thing. The doctor knew best, and the doctor told patients, and the patients just accepted. They said, yes, doctor, thank you very much, doctor. And the current concept is one of self-determination, and this is where the whole consent process comes in, as well as capability and capacity. It's communication between a doctor and the patient ultimately consenting of their free will to a procedure. And then, somewhat tongue-in-cheek, I say self-diagnosis is the next evolution, where patients come with a cell phone and say, you know, I read on Google, or they show you a pair of boobs and say, this is what I want, or make me this, or I want lips like this person's lips, regardless of whatever the doctor says. And then, in a sort of darkly ironic way, the amount of oversight that we have at the moment is really getting out of hand. There's all kinds of committees, oversight committees, medical aid committees, things like the Health Professions Council. And this regulation oversight is aimed at being for the best, but often they tell doctors what you can and what you can't do. And in a way, we've been subject to paternalism now as on the receiving end of paternalism, which is kind of darkly ironic that the cycle is almost back to the beginning again. This plays into whether or not we should do aesthetics during the pandemic. Some patients are just going to say, well, listen, I want to have my procedure and I don't care about COVID. Basically, just give it to me. You can tell them there are some risks to COVID, and even if they understand it and they have the freedom of choice, this is strongly presupposed on liberal individualism. Of course, some special consent might be needed. And we do have some potential benefits to individuals, the individual patients, and of course to practitioners for carrying on, as we'll speak about in a second. But this is strongly influenced by the view of liberal individualism. In other words, if it's not really harming anyone else, why should I care? I want it, I want to have it. Versus the preservation of resources for community benefit, such as communitarianism, that's a strong communitarianism base. And legislation as well as regulation from professional bodies, not a PRASA during the current pandemic, but I know the ophthalmology board restricted the activities of their members, and then individual hospital boards can restrain practitioners. And it seems somewhat unwise to go against this. So if your hospital, if legislation comes into being, or if a professional body says that you should not perform a certain type of surgery during the pandemic. It seems unwise to go against this, despite whatever liberal individual beliefs you might particularly have. If we look at the benefits and the risks during COVID of patients having aesthetic procedures, I've divided to these 4 blocks. So we can look at the benefits to the practice and the risks to the practice, and the benefits to the patients and the risks to the patients. So things like surgeon income and surgeon morale, because who didn't feel completely depressed during the pandemic, as well as the practice income for your staff and the staff's morale. These are not insignificant things to be just glibly mentioned. In America, they estimated 1.4 million people in healthcare were out of a job in 2020 because of the pandemic. 1.4 million people suddenly unemployed. And I don't know how many plastic surgeons had to get rid of their staff. In addition, the CCMA in South Africa reported a 156% increase in Section 199A complaints of people being dismissed because of COVID, people going out of practice. So there are benefits to doing such work during a pandemic. And then, of course, there's some risks. So surgeons may be exposed to COVID, patients may have exposure to the virus, and then a social outcry. If you post on your Instagram account that you're doing procedures, you can face some significant social outcry. And then there's the exposure to litigation if there were to be complications specifically related to the virus. If we look at the patients, things like a morale boost for the patients, lots of patients, and I'm sure all of you have experienced patients saying, I see how I look on Zoom, and I definitely need a blepharoplasty because I'm looking absolutely terrible. I just need a morale boost because now I'm working from home all the time. And these are positive benefits that the patients experience. They might have increased tolerance for downtime because they don't have to go to work. They might have spouses who are there at home to support them. And a lot of patients were planning on going on a skiing holiday, and now they can't. So they have extra cash flow, and they're coming to your practice to spend it, which is a benefit to the patient, that they now have this money to do their breasts or their eyes or whatever. And then the risks that the patients face of viral exposure and unknown risks, because we don't know all the strange things that could happen with COVID. On some of our plastic surgery groups, we're talking significantly about those things. And then there's the normal complications that happen, as there would in any procedure. There's complications to any kind of surgery. And one of the biggest issues is what happens if a patient has normal complications, not COVID related, and there are a lack of resources because of the pandemic. So these are additional risks. And what was the situation in South Africa? So if you haven't seen this, what impact did COVID have on plastic surgeons' practices? And for all of those of you who did complete the APRASA survey, we note that up to nearly 40% of practitioners had a severe impact on their revenue during the pandemic. And a minimal impact was absolutely a minority of plastic surgeons had a minimal impact. And if we look at what was their percentage of income compared during the lockdown period to the normal, you can see that a significant amount of plastic surgeons had to use savings to carry on their practices, to continue to pay their staff, or to let go of their staff. So this is not an insignificant thing to consider, especially now that we're potentially looking at a third wave. And then once we'd moved to level 2, many practitioners went back to work, and you can see practice improved, but it's still not nearly what it was before. So we have continued impact in terms of what we're earning, and the risks and benefits to our staffs and to ourselves. As I said, distributive justice is probably one of the most difficult things. Economics will determine the size of the pie, and politics determines how you cut the slices. And what are the slices? Well, there's all kinds of things like protective equipment and OR time, and how many vaccines are available and who's going to get them. I mean, should plastic surgeons be first in line to get the vaccine? And then hospital beds for elective cosmetic procedures. Distributive justice always looks at optimal utilization of resources. And what we need is a new paradigm, because none of the paradigms that we've ever used before are currently of much use. What we've always used before, certainly as plastic surgeons, is libertarianism, which is based on liberal individualism. It's those who want can get. So if a patient can afford to have a breast reduction, they come to office and you book them for a breast reduction. I mean, this is how cosmetic surgery and aesthetic procedures have always worked. That's the distributive justice model that we've worked with. Things like egalitarianism or perfectly equal distribution, like you're going to do 3 breast reductions, two breast augments, you're going to do 5 cancers first. A perfectly equal distribution hasn't really worked, and needs distribution. I mean, how many patients need a breast reduction but can't afford one? I mean, these are not things that we've ever used before. To explain the libertarianism paradigm more specifically, and how it works for plastic surgeons, and how it's ingrained in Western society, this is how the principle goes. People own themselves, and they own anything that they work for, as long as it's not to the detriment of others. So they acquire things from their labor, and because of their labor, and they own themselves and their labor, they may acquire a disproportionate share. Like you can become a millionaire or a billionaire. And then once you have it, you have complete freedom in the dispersion of your resources. And this is how the free market principle and capitalism works. But does it still work like this during the pandemic? So what did plastic surgeons do during the pandemic? You can see that a significant number of them continued to perform despite the fact that the law was against them, and that during level 5 practice, the level 5 lockdowns, we continued to work. Did plastic surgeons volunteer to participate in treating COVID patients? Interestingly, the majority did not, but I'm not sure whether that's an active decision, or whether plastic surgeons worried if there was nothing else they could do. So you always have to make a conclusion. You always have to come up with some recommendation. And I'm going to suggest that this is my recommendation of, should we perform cosmetic surgery during the pandemic? There is a difference between a captain and a general in an army. And a good captain won't make a good general, because the duty of a captain is to preserve his soldiers while following the orders that he's given from the general. Whereas the duty of the general is to win the war at all costs. So a general is utilitarian, and a captain is more of a deontologist. And essentially, we're the captains of our practices. We're captains for our staff and for our patients. And so while we do have to follow the orders of the law, which is above us, understand that the law is looking to win the battle, and not specifically at the individuals who are going to be the soldiers on the battlefield. So when you have skin in the game, when you have patients that you have to see, patients who want to have cosmetic procedures, patients who potentially need cosmetic procedures for whatever reason, and you have staff that you need to keep going, you behave differently when you've got skin in the game. So what's my recommendation? We're all captains, and as captains, we have to preserve our men and women, the patients, as well as the staff that we have in our practices, but also to follow the law that is on top of us. So while we have the go-ahead, I say we go ahead, of course, looking to look after the patients, make sure that you're following sterilization guidelines, etc. And then somehow do your best to balance both of the above. Thank you.
Thank you very much, Dr. Murdoch. That was very informative, and I actually see that it's very complex at the same time, because it's talking both from a moral point, an ethical point, and also from an economic point for plastic surgeons. I think that was great. I can now better understand why we were fighting a lot with some plastic surgeons during the COVID, pandemic, when we were at level 5. We had a lot of complaints. We had a lot of toing and froing about what's happening in your practices. Thank you very much. I see that, just check. There are questions that were posed. I think the first question relates to informed consent. And I think you did touch on informed consent. And the first question is around, is there a special informed consent that one needs to develop that is related to doing aesthetic, procedures during the COVID pandemic? Do you need to rework the informed consent? That's the first question. The other question on informed consent is post-operative care, to say, how do you avoid pitfalls? You have done a procedure that maybe in the eyes of others may find it not really necessary, and now you're in the COVID pandemic. How do you avoid pitfalls, post-op pitfalls, when you have done a procedure that some may seem to think it was not really necessary? I think those are difficult questions that I saw. Maybe even Mashuma or Prof can chip in.
Well, so I just saw that there was a question. Sorry, I just said sorry about dismissing the question. I'm going to answer it live about the COVID consent. So I have a special COVID consent for during the pandemic. So patients signed their normal consent and a special COVID consent now.
I agree with Marshall. I think that's exactly the way to go. Some of the hospitals also have their own consent forms which relate to COVID. I think Mediclinic does have one, where if you want to operate on someone, there's a special consent form that the patient needs to sign, which the doctor needs to take consent from the patient, which shows that the patient has been informed that there is COVID, there is possibility of contracting COVID, but also complications relating to COVID. So I think you do need to take special consent for if you're going to be operating on non-emergent situations for COVID specifically.
So the advice would be develop these, if you have not developed them already, develop, or amend your normal consent forms to actually include the COVID risks whenever you do these procedures.
Yeah, our association has actually provided our members with a template which they could modify according to their own sort of liking and so on, which pertains to COVID itself, and surgery. So we do have a rough guideline for the consent forms and things like that.
Right. Thank you. Anything, Mashuma?
Nothing much from my side, merely to say that it is something that has actually found its way by way of query to the claim team too. So it's definitely something that doctors, I suppose, are taking into consideration and actually effecting by having these separate and COVID consents, and sometimes I also suppose to include it in the existing consents.
Thank you. The other question I actually have is, Marshall, you spoke of the committees of use. Is that what I think that's what you called. Is it necessary? Is it necessary that the aesthetic surgeons have to consult, or the mere fact that they know, is it a recommendation, or is it something that you, as say APRASA, you would like them to actually look at whatever the committees are that would give them guidance to perform these procedures?
Well, I think, and Tim can also give an answer, but there was a lot at an ExCo level looking at whether or not we should provide a sanction. So I know the Ophthalmological Society basically said that their members were only allowed to do absolute, like, eye-threatening emergencies. Think of the benefits of cataracts. They were absolutely forbidden, and their society came out with a really strict guideline to say, do not do cataracts or any kind of refractive surgery until we give you the go-ahead. But many of the other societies didn't, and it was a very tough decision. But we chose sort of like to defer to the practitioners themselves, knowing that most people would actually act in the benefit of their patients. I know, Tim, there was a lot of talk. We read a lot of stuff.
Yeah.
Process guidelines.
So that's exactly what we did as an association. We actually looked at worldwide guidelines and so on, and we came up to certain conclusions. As an association, we can provide some form of a recommendation and a guideline, but we also understand that each medical practitioner and each plastic surgeon has got the right to actually perform what they, for their patients, what they think is important and not. So we provide guidelines of what we thought was ethical at the time. And it was also very important for us to realize that a lot of the level 5 sort of situation, it was the actual hospitals which guided a lot of their surgeries. So a lot of the hospitals actually stopped elective surgeries themselves. So that's where we were assisted in this manner. So a lot of the hospitals, when they stopped the elective surgeries, it was made easy for the actual plastic surgeon to actually not do any elective surgery because the hospital wouldn't allow it in the first place.
Well, that is good to hear, and hoping that the members actually, they understand the position that you guys, from the leadership point. The question that we always get, and which is somehow difficult for us to answer from plastic surgeons, it's around unattached, procedure rooms, where they would ask that, look, I've got a theater in my own practice, those practices that are not in hospitals. And they said, can I go ahead and do my, aesthetic procedures in those rooms without, feeling, as you put, Marshall, that is it really necessary to do it? Am I working as a captain, or am I working as a general? We always find it very difficult. We can answer from a medical legal point, but we struggle to give a very clear and a concrete answer to that question. Are you able to help?
Who, me?
Well,
so I also had my own little mini theater. So in a way, we've been really fortunate, because a year ago, we didn't know which way this was going to go. Were there going to be thousands of dead bodies in the streets? Or was it going to kind of peter out? And there was a lot of misinformation. People said this is nothing worse than the flu. So clearly it is a little worse than the flu in terms of mortality and morbidity. It's sort of 10 times worse than the flu, but it's certainly nothing on the level of like the plague of 565 AD, which took out a quarter of the world, the known world's population. So as pandemics go, it's been relatively more mild. So in terms of risk and benefit, if you have your own theater, so sterilization risks, it's been shown that transmission on surfaces is much less risky than transmission from droplet spread. And in terms of the number of people, so going to an acute hospital to have a procedure, you'd have to go through a casualty, you'd have to go through a reception. There's so many more places to come into contact with people. In terms of risk of COVID, it is much, much safer, I believe, to do something in your procedure room where it's you, an anesthetist, and maybe a nurse, as opposed to, so there's 3 people that you're potentially exposed to, and there's space requirements as well, as opposed to, going to an acute hospital where you might be exposed to 50 people. But it's also easier if you own the facility, because, you can say, I do not think that I should close my practice. So, for level 5, I definitely did. I stayed at home for 6.5 weeks and was bored and really depressed during that time. But as soon as the level 4 came, it was a decision I took, just to put my head out there. But yes, I think there is actually a lower risk now, but at the time we didn't really know. So it was a bit of a balance between paying staff and keeping salaries and keeping nurses employed. So the hospital closed. I had to employ nurses like myself, which was, several of them lived through the pandemic on what I gave them. So, I kind of feel I did good. And also I carried on in my procedure room doing pro bono work. So I do some once a month at the state hospital, and the state hospital was closed. And so all of those patients who came for their skin cancer, which I do, I did them in my procedure room. So I kind of felt like I'd done some good as well. I didn't just do blepharoplasties. I also, did some people who didn't have money and had skin cancer that couldn't, wait a year for their SCC to be cut out. So, on the balance of it, I felt like I was a good captain.
So, you know, this has got multiple levels on it, Dr. Klombe. You know, to answer your question, there is no doubt that certain procedures are, without a doubt, safer done under the COVID pandemic in the rooms. But obviously, there's a limit to what you can do in the rooms safely. But little skin cancers and even some aesthetic surgery can be done in your procedure room very safely, and more safely than doing it as a patient who's being admitted to the hospital. However, this raises another question of what is allowed to be done in a procedure room by the HPCSA and what is a registered theatre. And I don't think that's something that we can get into right now, because that is a debate that's you know, at the HPCSA level.
You've actually, you know, answered my next question, because the next question was going to be, is there, you know, a discipline guideline or a societal guideline, a society from, say, an APRASA or the surgical disciplines, where you'd have, there's a guideline now of really saying that if you want to do some procedures in unattached rooms, these are the guidelines. But I think you've answered that question. I think we have several other questions that were HPCSA related, and I think, Mashuma, you've dealt with those in writing. And we had a few questions that were talking about generally consent forms. The other one is around the protection of POPI, Protection of Personal Information Act. We had another question related to the litigation process. I just want to make sure that all the people that have actually submitted the questions, some of those questions, you know, I will try, or we will try as a team to reply to the individuals directly, because in a sense, we don't want to, you know, digress from the topic of today, but we will address those questions directly. This is the question. I think I should just read it out for all of us. What can the doctor do to minimize the complaints that the patient did not understand the complaints? Why didn't the patient raise their concern about the consent prior to surgery? I think, Mashuma, you'll be the better person to answer that question. I'm putting you on the spot.
No problem. Maybe Dr. Shlombe, there were two parts to that question. If you can maybe repeat it, please, and then I can definitely answer it.
It says, what can the doctor do to minimize the complaints that the patient did not understand the consent? Meaning, how do you as a doctor make sure that the patient understands? And the second part is, why didn't the patient raise their concerns about the consent prior to the surgery?
So I suppose I'm going to have to speculate to say why they didn't raise the concerns, but I suppose the one thing I always think, if you're in a position of a patient sitting across the table from a healthcare practitioner, and I mean, it's stressful already receiving the information that you're receiving, and the knowledge gap, I suppose, is and so I suppose it's just this overwhelming amount of information. So it's not necessarily to say that the patient understood everything, I suppose, in as much detail. So as to why maybe they didn't question it, I unfortunately don't know. But I suppose one way is to, I know what we at the claims team, or in 2019, a document or a guideline, an informed consent document was actually performed or was actually drafted for SASOG. And in terms of that, informed consent document, it also makes reference that can be used as a guideline to any of the practitioners. And I mean, they're welcome to request it. It makes reference to information booklet. And I suppose following what I said when we actually spoke about it, I suppose something like this could be used as a way of protecting doctors and ensuring that this information can actually get to the patient, and then I suppose later on, or even before the operation, they can actually sit and apply their mind to the information being given there. Perhaps maybe that's a good idea too.
Yes, I agree with that. I mean, this is a common question that we get. And one of the things that we give as an advice to the practitioners is that, firstly, the language that you use in describing the risks and the benefits and the processes, yes, it's understandable, and you try and you put it as simple as possible. But that patient at the time is very anxious. He or she doesn't, she's thinking, am I going to be alive or not? So the process is for the doctor to actually, follow what is prescribed in terms of the benefits, the risks, the alternatives. You record that properly. But that doesn't stop the patient from complaining. Because as we said, the knowledge gap, the language that we use, the anxiety levels are different. However, once the complaint is out there, you would have been protected by your informed consent process. The second other thing is patients will always complain. You can have the perfect informed consent. If they stay in ICU, there is a revision of the operation, there is sepsis, they will always come back and complain and say, you didn't tell me about these, because they did not understand, they have forgotten about it, or they've been influenced by other people. So the process really is to protect you as the practitioner, because there's nothing we can do to prevent patients from complaining. They can complain after signing a perfect, informed consent, but you'll be protected and you will not be found to be negligent. The second question that I always answer is, don't be angry at the patient when the patient complains. Just try and understand that the understanding level between yourself and that patient at the time was very different. So when they start, it's not like some of them, they are fishing, yes, but there are others that really are genuine in not properly having understood the discussion. So, the important part is the consent process. Do it to ensure that the patient understands, but more than anything, you do it to ensure that you are protected. You are not going to be found to have been negligent after going through a thorough informed consent process. We are coming close to an end of the webinar. I will allow just maybe one last word from Dr. Marshall and Mashuma and Prof. Just one last word before we close. In any order.
I'll do it quickly. When it comes to ethics, you can have vastly different views, and there are people who might have strongly different views to me. It doesn't mean that they're right or I'm right and they're wrong. It's just about getting a system in place that you can defend your view if anyone does ask you. If that's the cheater's way out of ethics.
Thank you.
I've nothing to add really. Just to say thanks to everybody who contributed today. It was very informative. Thank you very much.
Thank you, Prof.
Dr. Shlombe, I also don't have anything particular to add, but I would like to say thank you for definitely hosting the webinar. It was definitely informative, and I hope that our practitioners could have found it insightful and could have learned something.
I think just to coming to a close, I would like also to thank everyone who has participated in the webinar, who has registered, who has taken their time in this cold winter afternoon to join us and participate. There are questions that people have posed. Those that we have not addressed directly, I'm just making that commitment that we will reply. There was a long question around, timekeeping and record keeping and the court system. We'll address that question. We'll be able to send it back to the practitioner that sent it and have a discussion. And most importantly, we'd like to thank APRASA for agreeing to come and give us this presentation. Dr. Murdoch, thank you very much. You're very busy, but you managed to get the time. Prof, thank you very much. And most of all, I want to thank Joe. And I want to thank Joe. Joe is the person that works behind the scenes to organize this. So thank you very much. Thank you, EthiQal, and thank you, the team.